Shilpa, we can start. Good morning and warm welcome to Online Anesthesia Postgraduate Teaching Program on Zoom platform, sponsored by Aquila and hosted by A1 Logics and aired by Anesthesia TV. Today we are having an eminent scholar in our session of obstetric anesthesia, Dr. ANJU GREWAL. She is going to deliver a lecture on anesthetic management of pregnant cardiac patient. Before handing over this session to coordinator Dr. SIVAPRASATH sir, I like to say a few words about Dr. ANJU GREWAL madam. Luckily, I have a few chances to work along with Dr. ANJU GREWAL madam for editorial writings in IJA and as a judge for the best IJA articles. When we were the judges for the IJA articles, surprisingly, we have selected the same articles for the best prizes without consulting each other. That happened 2 consecutive years. I think, madam, you remember that. So it was a great learning experience to work along with her. We are immensely pleased to have such a renowned scholar in our online anesthesia platform. Thank you, madam, for being with us today. With this introduction, I invite Dr. SIVAPRASATH sir to introduce the speaker and coordinate the session.
Good morning, everybody. Welcome to Online Anesthesia, yet another session of obstetric series. We've been priming you all with obstetric anesthesia in the few past weeks. Today, we have a very important and interesting topic, which could be even a nightmare to the eminent anesthetist. On one side, we have challenges in physiology combining with the pathological changes in cardiac disease. So we are very eager to hear how to manage a pregnant patient with cardiac disease from ANJU GREWAL ma'am, who is the professor and HOD of DAYANAND Medical College and Hospital in Ludhiana. Her main area of interest is in obstetric anesthesia, where she holds the chair of Obstetric Anesthesia Society, and she is also eminent in airway management, CPR, trauma anesthesia, and scientific communications. And I know her more because she was the vice president of Research Society of Anesthesia and Clinical Pharmacology. Her editorial articles in JOACP journals would be very interesting. And she also has been a National Secretary of Obstetric Anesthesia, the Associate Editor of International Journal of Regional Anesthesia, and Coordinator of the Code Blue team in her hospital. Welcome, ma'am. We are very eager to hear from you. Over to you, ma'am.
Thank you so much for such a generous introduction, Dr. SIVAPRASATH. I'm indeed honored by yourself and the entire team. Thank you, Dr. Edward, for inviting me to talk on a very pertinent topic. And indeed, I took it as a challenge because this is a topic, as you rightly said, can cause nightmares even to an experienced anesthesiologist. So I'll start with greetings to all of you on a Sunday morning. It is indeed heartening to see that we have a good number of postgraduates joining this session. Thank you, Dr. Edward, for this opportunity. I bring you greetings from DAYANAND Medical College and Hospital, the place where I work. So in the next, I'll try to be as brief as possible. And if you find that I'm going a little overboard, you can please feel free to stop me and we can have more discussions. So we like to, in the talk, I like to look at the concept of a cardio-obstetric team and the role of anesthesiologist in this heart team. What are the various risk stratifications available and on which we can kind of predict what the patient has the possibility of a major adverse cardiac event happening. And then what are the implications of the cardiovascular physiological changes on the underlying heart disease in pregnancy and how do they affect our anesthetic implications? And then, of course, we'll look at how to manage a vaginal or a cesarean delivery in this parturient, special group of parturient, I would say. And then briefly focus on specific conditions like mitral stenosis, severe pulmonary arterial hypertension, and cardiomyopathies. Now, why are we discussing the topic? Partly because we all believe that it is indeed very difficult to understand. And there is a mother who already has some compensatory mechanisms going on the cardiovascular system. And then on top of that, we have an underlying heart disease that has its own set of issues. And why has this become so much more common is the fact that many of the women would initially, in the initial years, not survive to motherhood. Now, with good, medical advances and surgical advances, I would say many of the women with congenital heart disease do survive to motherhood. On top of that, there is a delay in the timing of motherhood. That means that we have mothers with advanced age and therefore have concomitant comorbidities like obesity, diabetes, and hypertension, which bring in forth their own challenges. Rheumatic heart disease, though is waning away from the West, of course, is still prevalent in many parts of our country. So we do have a challenged mix of both valvular heart lesions, cardiomyopathies, and of course, congenital heart diseases. So if you look at the categories of cardiovascular diseases in pregnancy, one, as I said, is a big chunk taken by valvular diseases, the mitral stenosis being the leader of the lot. And now we have a lot of women coming with prosthetic valves with pregnancy coming to us. Peripartum cardiomyopathy is on the rise, right? And there is a lot of incidence of association of severe preeclampsia happening with peripartum cardiomyopathy. So this is something that we really need to look out for. Then, of course, there is a few incidences of aortic diseases and aortic dissection. Prominent among them being Marfan syndrome, bicuspid aortic valve disease, Turner's syndrome, and Ehlers-Danlos syndrome. And then we have, we have the congenital heart diseases, the cyanotic and the acyanotic heart diseases. And of course, pulmonary hypertension. Once in a blue moon, you do get an Eisenmenger syndrome coming with pregnancy to us. And of course, other issues like pregnant patients with implantable cardiac devices, etc. Now, though it is a leading cause of maternal mortality and morbidity in the developed world, we are also slowly entering into this particular world. And as I said, we have a good mix. So we really need to, take measures to reverse this trend or not go into this trend that the Western counterparts are in. And what do we really need to do is to have a multidisciplinary team, something that we call as a pregnancy heart team, which should comprise of mainly a obstetrics experts, including people from cardiology, maternal fetal medicine, obstetrics, and a prominent role being played by an anesthesiologist. It could be an anesthesiologist who is a specialist anesthesiologist in obstetric anesthesiology, or an anesthesiologist who does a lot of obstetrics, obstetric anesthesia, and has a fair good knowledge of cardiology as well. So of the varied roles that this cardio-obstetric team plays, our role as an anesthesiologist basically focuses at risk assessment. So where we are actually looking at risk stratification so that we know that whether or not we have the resources in a hospital to take care of this, or does this patient needs a transfer to a higher level of care. And then, of course, when she becomes pregnant, so this team not only counsels or takes care of the mother while she is pregnant, but also takes care of the mother in the preconceptional time periods, where they do offer them advice on whether or not to get pregnant and how to optimize their medical status before getting pregnant. And then, of course, we need to then proceed once pregnancy occurs in such mothers with cardiovascular diseases, how to plan her pregnancy, the labor, how to support her labor and delivery, and including the postpartum period. What we have to remember is that the postpartum period in these mothers where they are vulnerable to heart failure can extend to as long as 16 weeks as also. So a long-term follow-up is extremely important, and hence to risk stratify them, we all are aware of the NYHA classification that we all do commonly every day, right? We ranging from class 1 where there is no functional limitation of activity to class 4 where there is severe limitation of physical activity. It's very important to sit down and talk to your mothers and understand their level of usual exercise and the exercise or the level of activity at which they are getting breathless or symptomatic, right? So to make it simpler for all of us, class 1, 2, and 3 will not show any symptoms at rest, but symptoms at rest, if they are present, that means the mother falls into class 4 NYHA grade. Whereas on activity, and you'll have to specify what is a routine activity for this mother, an ordinary activity, and an extraordinary activity. So if there are none, it is in class 1. Mild symptoms would be in class 2 and 3. And then, of course, if there are severe symptoms, because the mother is already orthopneic, she is tachypneic or even on rest, this would, of course, fall into class 4. So a simple way to look at, remember your NYH, a very important way of risk stratifying your mothers, and will help us to decide the type of anesthesia we're going to give to these mothers. Then there have been various scores, the CARPEG 1, the CARPEG 2, the Zahara score, and the modified WHO risk score for cardiovascular complications. Now, what we have to remember is that these scores are basically looking at either individual maternal risk factors, like in this particular case, they're looking at any history of prior cardiac events or arrhythmias. They're looking at the NYHA status, the pre-pregnancy NYHA status, and the presence of cyanosis currently, looking at valvular and outflow tract obstruction pathologies and myocardial dysfunction. And they have a score for each of them present. And then depending upon the cumulative scores, we can predict the incidence of post-operative cardiac or peripartum, I would say, cardiac complications in this mother, right? So this is the CARPEG score, which came lately in 2018, has yet to be, compared to the previous scores. And it incorporates the elements in red, which are newer elements over the CARPEG 1. So they have incorporated presence of a mechanical valve, presence of pulmonary arterial hypertension, coronary artery disease, which is on the rise in pregnant mothers as well, high risk iotopathy, cardiac intervention, yes or no. It should be prior cardiac intervention, and then late pregnancy assessment, the mother coming to you quite late. But of all these of these scores, one of the scores which scores best in actually risk stratifying more accurately is the modified WHO cardiac risk assessments score. So if you look at this score, the class 1, mothers who fall into class 1 have a low risk of maternal mortality, that is less than 1%, because there is, it usually encompasses situations like uncomplicated mild pulmonary stenosis, a small VSD or a PDA or a mitral valve prolapse, with a trivial MR, and maybe some successfully repaired simple lesions. So these are mothers which fall into a low risk category for maternal mortality and morbidity. Class 2, there is a small increased risk of maternal mortality, but a moderate risk of maternal morbidity. And this would include unrepaired ASD, VSD, repaired tetralogy of Fallot, and some of the arrhythmias that you commonly encounter. And mothers, we usually encounter atrial arrhythmias more often than the ventricular arrhythmias. Now, there is a group between 2 and 3, which will depend upon the patient profile, so which can vary from hypertrophic cardiomyopathy to native valvular diseases as they're evolving in their milder forms. Marfan syndrome without an aortic dilatation or a bicuspid aortic valve of the aorta with a diameter of less than 45 millimeters, or a mild ventricular impairment coming in. So they have a mortality risk of around 5 to 15, but remember, the morbidity here climbs a lot, right? Very clearly, mothers who fall into class 3 are those with mechanical valve, a systemic right ventricle, having a Fontan circulation, and unrepaired cyanotic heart disease. Marfan's area, where you're again in the gray zone, you're more than 40 and but less than 45. And so these are mothers where you will expect severe morbidity. Of course, the mortality stays below 50%. But that's a pretty big mortality that we're looking at, 50%, right? And offering them various contraceptive methods to avoid a pregnancy, because the mortality rate can climb from as high as 40 to 100%, and they include severe pulmonary hypertension with an Eisenmenger syndrome coming in, a systemic ventricular ejection fraction of less than 30%, dysfunction where the mother moves to class 3 or class 4 of NYHA grade. There is severe mitral stenosis or a severe symptomatic aortic stenosis. Remember, symptomatic aortic stenosis is an ominous sign for high risk of mortality. Marfan syndrome with an aortic diameters above 45 and a bicuspid where the diameters are above 50. Now, these are kind of, mothers that are going to be at very, very high risk. And we all know that despite pregnancy being contraindicated, we do get mothers pregnant with all of these up there, isn't it? So to summarize, what we're looking at high risk conditions are those have an underlying or a primary severe pulmonary arterial hypertension, those with aortopathies, and there is a dilatation of the aorta, the diameters are above 40 and 45, or a left-sided obstructive heart disease, especially the severe mitral stenosis and asymptomatic aortic stenosis, and of course, now the rising trend of peripartum cardiomyopathy. So these are all which, we are going to pose risk, and most of the times your obstetricians are going to plan a cesarean delivery for them. And therefore, in the initial period, when the patient comes to you in the pre-anesthesia evaluation, it is important not only to consider what their functional status is, but also important that we look at our resources and decide whether the mother can be cared for in your own hospital or needs to go to a higher risk, higher level of care, say a level 3 or a level 4 care, right? And very important is whatever is your plan, and I find this part very important, is to develop a plan and then disseminate the management plan to all members of the team. Everybody on the team should know what we are going to do and what our backup plans are. So how to decide and plan a particular, delivery for these mothers? It is important first that we, we'll look at the general approach. I'll be talking more as on a broader outline. And then, of course, briefly, we'll look at individual diseases. So we need to understand the adaptation of the cardiovascular physiology to normal pregnancy. And then, of course, understand that if a mother has already an underlying heart disease, how does these cardiovascular changes that are imposed because of the pregnancy affect the underlying pathophysiology of the heart disease? And what are the anesthetic implications, intertwined with that? So if you look at, I know there was an entire session on physiological changes of pregnancy taken by Dr. Akhil, and it was a wonderful session. I just briefly touched, briefly touched the cardiovascular physiology, wherein we are all aware that the cardiac output is the one which starts to increase from the first trimester itself, very early on from the first trimester. And this is basically driven because of the increased sympathetic activity and the presence of hormonal influences. And therefore, there is a placenta that needs to be supported, and there is a fetoplacental unit. And therefore, the plasma volume is one of the major drivers for increasing the cardiac output, right? So as the increase in the plasma volume occurs, the cardiac output starts to increase across the 3 trimesters, and it exponentially increases beyond, it is up to 50%. It increases, peaks at 32 weeks. But when the mother goes into labor, it is an additional 50 to 80% increase in the cardiac output that we witness with each contraction that is occurring up there. Okay. So we need to understand that there is a hypervolemic state happening in this mother. And to compensate for that, what does the heart do? It increases its stroke volume and initially, and then it also increases the heart rate. So there is a resting tachycardia and there is an increased stroke volume, right? And of course, the blood pressure is kept at normal because the systemic vascular resistance drops down consequent to the increase in the cardiac output. It keeps decreasing to accommodate for this forward flow of this increased hypervolemic state of this mother. Okay, so and because the stroke volume increases is secondary because of the eccentric hypertrophy that you see in the left myocardial wall mass. So these are the basic changes that are occurring during this time, and we really need to understand them so that we are able to look after these mothers appropriately. So this is just a graphical display of what I said. The rise in the plasma volume and the cardiac output begins early in pregnancy, and it actually starts to peak somewhere around 16 to 20 weeks. And this increase is brought about mainly by stroke volume in the initial period, and in the later period especially during labor, by the heart rate. The systemic vascular resistance, on the other hand, drops down all throughout the pregnancy. What we really need to understand is that at the end, during labor, the latent and the active phase, there is an additional increase in the cardiac output. And in the immediate postpartum period, which is the most vulnerable period, especially for patients getting into heart failure, is a period where 80% of the cardiac output is going to increase secondary to autotransfusion, because the uterus is now involuting and the fetoplacental unit, which was sitting over the inferior vena cava, the aortocaval syndrome, is now totally relieved. So that's the amount of stress that the heart now takes in at the immediate postpartum period, right? So we are all aware of the aortocaval syndrome, the supine hypotensive syndrome, that we know that actually when the mother is lying supine, might decrease the cardiac output. And therefore, in the 3rd trimester, when you measure the cardiac output with the mother lying supine, it will show you a decrease in the cardiac output. Whereas if the mother goes lateral, or there is an evacuation at the end of delivery, this entire volume is also going to add to the already increased plasma volume that is there in this pregnant mothers. Now, to compound problems for us, we all know that the colloid oncotic pressure in the pregnant patients is reduced, and therefore the gradient between the colloid oncotic pressure and the capillary hydrostatic pressure is actually reduced, and this leads to pulling of the water into the interstitial space, and therefore there is a risk of pulmonary edema. Of course, this gets accentuated in conditions like preeclampsia, where there is a vascular permeability also underlying. So what is the impact of physiological changes on a normal mother? She's going to, of course, we know respiratory wise, she breathes more. She has some amount of hyperventilation, which leads to respiratory alkalosis. We know there is a decrease in the functional residual capacity. And sorry, she pumps more because there is a hypervolemic state. And therefore, there's an increase in cardiac output because of the increase in plasma and blood volume. And there's a consequent increase in the stroke volume and heart rate. And then, of course, this is accompanied with a reduced afterload, that is a decrease in the systemic vascular resistance and the peripheral vascular resistance, as you would call. And of course, these mothers are thrombogenic, and therefore they clot more, and therefore, young mothers, they fight more to us. But what we need to understand is that a pregnant mother who does not have a cardiovascular disease might be breathless, might have fatigue. So therefore, there is a lot of confounding occurring when to label them on the basis of their symptoms and signs as to the ones who have an underlying cardiac disease. Many a times an underlying latent cardiac disease is indeed unmasked because of the pregnancy, right? So it's known as pregnancy is known as a stressor to the heart. Now, what are the signs and symptoms that should, put a red flag into your mind is if the mother says she has shortness of breath at rest. She gives you on an inquiry, she gives you symptoms of paroxysmal nocturnal dyspnea, orthopnea, as I said, breathlessness at rest. Then, of course, chest pain or breathlessness on minimal exertion, or of course, exertional or unprovoked syncope, palpitations with near syncope, and of course, extreme fatigue. And one of the symptoms that I rate very important is a mother who said, I could lie supine, but now I need 2 to 4 pillows to lie down when I sleep at night. But this is a mother where a red flag should be activated. You must examine her. And if you find persistent tachycardia, hypertension, or a symptomatic low blood pressure, a tachypnea, which is beyond 25 breaths per minute, and a saturation below 95% at room air, with, of course, signs like visible JVP 2 centimeters above the clavicle with the mother at 45 degrees, a loud systolic murmur. Remember that there would be flow murmurs, systolic murmurs in a normal pregnancy, but if you have a diastolic murmur or a loud systolic murmur on an S4 being heard, this is a mother that might be harboring a underlying cardiovascular disease. And of course, wheezing, lung crackles, marked peripheral edema are ominous signs for pulmonary edema and heart failure coming in. Now, to understand the whole gamut, I have actually looked at one of the articles which talked about a cardiac grid, and I found these very important. So there are actually 5 elements that need to be taken care of or understood when we are looking at a pregnant mother. So in a normal pregnant mother, we all have understood by now that there is an increase in the preload because it's a hypervolemic state. There's an increase in plasma volume during pregnancy, all the 3 trimesters, and then which keeps on increasing and therefore leads to an increase beyond 40 to 50% of the plasma volume. So the preload is increasing. And when the mother gets into labor, there's an additional load coming onto the heart preload. Coming because of the uterine contraction. So each uterine contraction is going to pump in 200 to 500 ml of blood per contraction. And of course, a major chunk of auto transfusion comes in because after delivery, when there is a decompression of the inferior vena cava, and of course, there is a uterine involution coming in in the immediate postpartum period. So the preload is increased. The myocardial contractility now has to cope up, and therefore there is an eccentric hypertrophy, and therefore the myocardial contractility increases, the stroke volume increases. In addition, there is an increase in the heart rate, especially more so towards the end and during labor and postpartum period. But what is important to remember is that in a normal pregnant mother, the mother maintains her sinus rhythm despite having a resting tachycardia. To compensate, there is a decrease in the afterload, and therefore there is a decrease in the SPR. the PVR by and large remains normal or might be slightly increased. So this is a grid that happens in the normal pregnant patient. Now we have to remember that when we're looking at individual diseases, right, we need to understand first what is the pathophysiology of that particular diseases vis-a-vis these 5 elements. And now on that pathophysiology, we're going to impose pregnancy over this, and these changes would come in. How would this mother react? And how I'm going to tailor my anesthetic regimen so as to stay close to this picture as we see, or as optimal as possible for that particular disease that we are looking at. So that's a broader way of how we are going to, look at these diseases. So basically, we understand that there is a pathophysiology. So we look at whether we have a preload sensitive or an afterload sensitive cardiac disease, or a cardiac disease which also has a diminished cardiac heart function. And what are the other factors that can indeed affect the mother's heart, which already has cardiovascular physiological changes coming in. Now the interplay of these two things is going to decide what would be the type of anesthesia and how we're going to tailor your anesthesia to this patient, right? And how you're going to manage this patient in the peripartum period, I would rather say more broadly. So the basic principles, the very broad principles are that we need to do a thorough history taking and a physical examination, come what may. 1. 2, you need to ensure that throughout the period of her peripartum period, especially at times where your interventions are needed, the sympathetic blockade that you're going to put in is minimized, and you are maintaining an optimal preload for her, not too high and not too low. The uteroplacental perfusion is always maintained. So you have to ensure, and of course would not be repeating this again, but you have to ensure that till delivery of patients, these mothers do have a left uterine tilt. A left uterine displacement is extremely important, from 15 to 30 degrees or more, right? So avoidance of aortocable compression is important. You need to monitor both the parturition and the fetus. Of course, we are more keen in the mother, but a fetus needs also to be looked into. And as a generic rule, aspiration prophylaxis should be provided to all your mothers. Now, if you look at the entire move from the preoperative period to the postpartum period, in the pre-delivery, what are your roles as an anesthesiologist? As I said before, and just to repeat it and reinforce it to you, we need to evaluate the cardiovascular status, the underlying cardiovascular disease and its pathophysiology, the obstetric conditions that are along with, and we look at the anesthesia aspects of and any other lurking. Say there's a difficult area, difficult back up there. So that kind of risk factors also needs to be taken into consideration while you're looking at these mothers, because they will add to the further risk, the comorbidities that the mother might have, the red flags that she is showing you, right? So we need to focus on all of these. For a cardiac history, you need to focus on her symptoms and signs, and of course on her previous surgeries. If she has some previous, records of her echo, ECG, Holter, or any cardiac catheterization done previously, on previous or current episodes of heart failure and arrhythmias, is she exhibiting cyanosis? Does she give you history of cyanosis? And are there any symptoms of left heart obstructive lesions? So all of these we need to look at, and then of course risk stratify them as we talked earlier about on the basis of the modified WHO criteria. And then as a team, as a complete heart team, we will plan one on delivery location. So what is the level of care that this mother needs? We need to look at the drugs that need to be utilized in her safely so that she can be optimized as much as possible for the delivery. And a prominent among those drugs is the anticoagulants that these mothers are usually into there. And of course, we need to talk to the cardiologist so that we have an optimal period where we can perform a neuraxial procedures safely. And then also discuss with an obstetric team that there would be a certain amount of drugs like say methergine or carboprost that would cause hemodynamic instability, terbutaline being one of them. And of course, look at other aspects if she has some devices in situ. So all of these need to be planned and communicated to each member of the team, right? Now, if the mother has been, planned for a vaginal delivery, and for a generic term, all cardiac patients need to undergo ideally a cardiac vaginal assisted delivery and not a direct cesarean delivery. The indications for a cardiac patient undergoing a cesarean delivery are very limited. most of the times you can, plan and have a planned vaginal delivery up there. And so if the mother is scheduled for a planned vaginal delivery, we need to initiate neuraxial analgesia in the safe period of our anticoagulations dosing timelines, until it is unless there specific contraindication, a neuraxial analgesia should be initiated as early as possible, possibly at the time where the mother has started to just get some discomfort, and not when she reaches some degree of dilatation or is in severe pain. So do it as early as possible. What is very important is to institute monitoring. And apart from the standard labor monitoring, you need to have 2 pulse oximeters. One pulse oximeter that is separate and is placed on the mother's, finger, which also has a waveform. With the waveform will tell you whether or not the artifacts that you see on ECG are actual artifacts or some other genuine arrhythmia coming in, or maybe there is a loss of pulseless electrical activity occurring in. So we need to have a pulse oximeter with a waveform. And another pulse oximeter can be incorporated as part of the tocodynometer that the obstetricians use in. A 5-lead ECG is pertinent. Most of these mothers would be vulnerable to ischemic changes. An intra-arterial blood pressure monitoring is something that is indicated in these mothers, and therefore, especially so if you are looking at mothers which have a left ventricular outflow obstruction, I would rather have them on all of my cardiac, pregnant patients with heart disease, because it is going to be of immense value to us, not only during labor, but also at times when this mother might need to be shifted to the operating room and converted to surgical anesthesia immediately. So, have that period covered up, because we have a beat-to-beat monitoring of the heart, of the blood pressure occurring with us. And if you have expertise and equipment for a transthoracic echocardiography, this can actually guide you immensely, right? One of the very good ways is that once you have placed your neuraxial block, get your staff on the labor floor to fill in a MEOS chart. That's a modified early warning score chart, which is specified or tailored to obstetric scenarios, so that we can in time, detect any slightest of clinical deterioration and, prevent a major catastrophe from occurring there. Now, while you're instituting neuraxial analgesia, there are a few pertinent points to remember. One is that we do not preload these patients. Remember, the pregnancy is already a hypervolemic state, and most of our cardiovascular diseases would be preload sensitive, and therefore pre-epidural fluid boluses are to be avoided in them. The timing, as I said, for in relation to anticoagulation doses while placing a neuraxial analgesia needs to be done as per the relevant guidelines of ASRA, or whatever guidelines are available at that particular time. And this is mainly because we want to prevent a spinal epidural hematoma from occurring. By and large, we have to remember that oral anticoagulants can be stopped for 4 to 5 days, and we need to bridge the gap with an unfractionated heparin. If you're using a low-dose unfractionated heparin, then you can stop them 4 to 6 hours prior to instituting a central neuraxial block. If the mother is on intermediate dose heparin, meaning thereby 7,000 to 500 to 10,000 units twice daily, then you need to stop it 12 to 24 hours before CNB. So high dose heparin is more than 10,000 units. So you need to accordingly time the stoppage of the anticoagulant and institution of your central neuraxial block. If the mother is on low molecular weight heparin, we all understand that if she is on prophylactic doses, a 12-hour period, and if she's on therapeutic doses, a 24-hour period of stoppage of this anticoagulant is important and pertinent before you institute a central neuraxial block. You can monitor the platelets, because there can be heparin-induced thrombocytopenia occurring along with thrombocytopenia of pregnancy coming in. And you need to look at the activated prothrombin APTT and the anti-factor 10A levels if they're available into your hospital before you institute the central neuraxial block. Some other important pertinent points as far as neuraxial block is concerned is that you might be looking at a mother who has a shunt or a kind of a VSD or a PDA or some kind of a communication between the right and the left circulations, heart circulations, and therefore it is pertinent that we use saline for doing the loss of resistance technique to confirm the epidural space instead of air. And the point about test doses, guidelines, recommend that we avoid using epinephrine-based local anesthetic test doses. Now, what we need to remember is slowly the world is moving towards avoiding the standard test doses that we use in non-pregnant women in pregnant mothers, right? We can use the same dilute solution of local anesthetic in small graded aliquots to act as a test dose for you. Remember, there is a baseline tachycardia. So by adding epinephrine, you're only testing the presence of the catheter in the intravascular space by an occurrence of 15% increase in the heart rate, where the heart rate is already increased by 15%. There is a lot of confounding into whether or not you can test the epidural using the conventional test doses. So therefore, in pregnant mothers, it becomes all the more important and pertinent that we avoid the test doses and use the dilute local anesthetic solutions in graded small aliquots to test the epidural. We must have a low threshold to replace suboptimal epidural catheters and must keep on testing that your epidural catheter is indeed working efficiently. And it's very important that in the second stage, we keep the epidural block dense, having a dense sacral coverage, because that will help to eliminate pain and catecholamine release during labor, especially during the descent of the head during the sacral coverage and when the rotation occurs. And this would indeed facilitate the vaginal delivery, right? And if you have a dense sacral coverage and you have a good working epidural catheter, it will also help us in quickly converting to surgical block. Suppose there is any kind of an obstetric emergency, a fetal distress, or a cord prolapse occurring, and therefore you need to rush this mother to the operating room for a cesarean delivery. So a good working catheter is extremely important. While you are using the epidural, remember to slowly load it in a graded manner so that we do not have any sudden sympathectomy occurring. That's the key to having a good working neuraxial block in epidural block for these mothers who have an underlying heart disease. So what is a cardiac vaginal delivery? Cardiac vaginal delivery basically means that the mother does not push. There is no valsalva occurring here, okay? Because intense valsalva is going to decrease the preload and increase the afterload. Is actually going to reverse the whole thing for the mother, right? So you do not want the pendulum to swing too violently on one side to other side. Therefore, no pushing. The uterus basically contracts and labors down the fetus. And for that to happen, you need an excellent, early, carefully titrated neuraxial labor analgesia, meaning thereby it's placed early, placed safely, it is working, and you are using small aliquots to build it up. And then, of course, you can have any of the techniques to maintain it, say a continuous labor epidural infusion technique, a PIAB, or an intermittent dosing occurring. But what you need to ensure is a dense sacral block coming up there, and you need to monitor your mother, because we want to keep the blood pressures, the systolic blood pressures at baseline, and we do not want to drop even to 10%. And therefore, in the context of cardiac diseases, phenylephrine infusions are actually ideal. And there would be some conditions where you do not want bradycardia coming in, and that, of course, we can use a mix of norepinephrine or ephedrine in some of the instances, but most of the times a phenylephrine infusion is what is indicated. Right? And at the end, oxytocin boluses are to be avoided. We have to remember that this would create a lot of vasodilatation occurring and a decrease in the afterload. And therefore, a slow, careful oxytocin infusion is advocated. Methergin and carboprost need to be avoided. And therefore, you also need to monitor your mothers for any hemorrhage or postpartum hemorrhage occurring in the postpartum period. Right? Now, if this mother, this was for vaginal assisted delivery, and of course, we need a cardiac vaginal assisted delivery, where we can employ low outlet forceps and all of them. Now, if this mother needs to undergo a cesarean delivery, remember, cesarean delivery is reserved for obstetric indications primarily. The major hemodynamic goals are that we maintain sinus rhythm at all times. We need to ensure an optimal preload and prevent sudden changes in systemic vascular resistance. Now, this sudden changes can actually occur not only with spinal anesthesia, but can also occur with general anesthesia as well. You can have drugs that can cause sudden drop in SVR, sudden myocardial depression. So they can also be equally dangerous, right? So it is not the technique, but how you do that technique is what matters in these mothers. We have to have a very low threshold. Rather, I believe it should be mandatory to place an intra-arterial blood pressure monitoring up there for these mothers. And if you are going for GA, of course, you can have T as along with your standard monitoring, other monitoring that you employ for these mothers. A central venous line and a pulmonary artery catheter are reserved for cases where there is severe decompensation or right heart failure, are not usually normally employed in usual care. Now, we can perform a neuraxial anesthesia, especially an epidural or a dural puncture epidural or a sequential CSE. Sequential CSE is more commonly used, where we employ an intrathecal opioid with a low-dose local anesthetic ranging from 2.5 to 5 milligram of bupivacaine, nothing more beyond it, as you would, according to your patient. Of course, you have to tailor to your patient and see whether and how much can she tolerate sympathectomy, and has to be graded, right? In conditions where a cesarean delivery needs to be done under GA, you have to be careful, and you have to know what are those conditions where a cesarean delivery for these mothers would be done under GA, and that is a large expanding or a dissecting aortic aneurysm. Your patient is in warfarin anticoagulation, or the anticoagulation is going on, and you do not have those timelines to put in a safe neuraxial anesthesia, so you would go in for a general anesthesia. A critical valvular stenosis, severe pulmonary arterial hypertension with cardiopulmonary decompensation, acute heart failure, and severe thrombocytopenia. Some of the indications where you would go in for a delivery by a cesarean route under general anesthesia. So these are some of the conditions where you would go in for general anesthesia. As a thumb rule, remember that if a mother cannot lie flat, she gets hypoxemic or dyspneic on lying flat, she needs pillows to lie down, she is likely to compensate on your table, and therefore you need to give her general anesthesia, intubate her, and control her acute heart failure very well, right? And once you decide for GA, the GA likewise is called a cardiac GA, where you try to titrate using opioid-based induction. Etomidate, sevoflurane are the hallmark of your anesthesia regimen. And of course, as I said before, intra-arterial blood pressure monitoring is the mainstay for maintaining stable hemodynamics. Right? Remember that at the end of delivery, if the baby is delivered, this is the period that you need to be very careful, because there's a risk of acute heart failure due to aortocable decompression and uterine involution. And another word of caution, if you're working on a mother who has a ASD, PDA, or a VSD, exteriorization of uterus, some of the obstetricians prefer to take out the uterus and then sew it out. That can lead to micro air emboli. So we must try and talk to our obstetrician, especially when working on these patients, to not to exteriorize the uterus if possible. As has been said before, a vasopressor infusion is mandatory in these mothers, right? So we need to maintain a baseline blood pressure to the baseline. We do not want any deviation up and down, right? Epinephrine or milrinone are drugs that can reliably provide cardiac contractile augmentation if you're working on mothers who have reduced ejection fractions and you need to improve the myocardial contractility. Oxytocin, as I said before, needs to be titrated on an infusion pump. And of course, we need to monitor for postpartum hemorrhage and any cardiopulmonary decompensation that can commonly occur in the immediate postpartum period because of autotransfusions, right? And the same things would go on in the later postpartum period as well. And there would be mothers who have class 3 and 4 lesions, which would require movement to an intensive care unit, right? And there is where your intensivist would also come into play. So this is to broadly make you understand how to approach a mother who has a pregnant mother who has an underlying cardiovascular disease. We'll look at briefly at valvular lesion, look at what our hemodynamic goals are and how would you tailor your anesthetic regimen. So valvular lesions, we'll look at valvular lesions first, right? Now, one of the most predominant valvular lesion that we come across is mitral valve stenosis. And we all are aware of this grading based on the mitral valve area. What we really need to remember here is that a mitral valve area above 1.5 centimeters square keeps this mother into a low risk zone where she will tolerate pregnancy and delivery pretty reasonably safely unless, of course, you have additional factors working in play. But a mitral valve area of less than or equal to 1.5 centimeters square will usually have an underlying propensity to get into pulmonary arterial hypertension or might have a pulmonary hypertension. And this mother would be moving into a high risk group where you need to look at this cardiac grid and remember that in mitral stenosis, we are looking at a further increase, if this mother is preload sensitive and therefore she cannot tolerate this preload, there would lead to an increase in the transvalvular gradient, which will predispose this mother to pulmonary edema. Further, moving this mother to pulmonary edema is the presence of tachycardia, atrial fibrillation, because the left atrium dilates as a result of the increased transvalvular gradient, right? And that would lead to back pressure changes and furthermore propensity to cause pulmonary edema, right? And because of the decreased oncotic pressures that we already have pre-existing in these mothers. And because there is a left atrial enlargement, there is a loss of atrial kick, and there is stasis of blood there could be thrombus occurring in these areas, and of course, small emboli can move out during contractions. The myocardial contractility might also be decreased in many of these cases, especially in case of aortic stenosis. And of course, the SVR, which is decreased, will lead to a reduced diastolic and coronary pressure, especially, more important to remember this in case of aortic stenosis, because there is a thickened myocardium, and any drop in the coronary pressure can lead to myocardial ischemia in these patients. So we have to remember that the pregnancy-associated cardiovascular changes are not conducive for a stenotic lesion. They are actually adverse for the mother, right? And therefore, when we look at a fixed cardiac output state, as we said, our hemodynamic goals basically focus on maintenance of normal sinus rhythm. We have to very, very diligently avoid tachycardia at all costs. For those who have low risk or a moderate MS, we can use neuraxial labor analgesia, which needs to be carefully graded and titrated, and there should not be a sudden sympathectomy occurring in these mothers. A beta blocker, if there is already one which is on board, should continue. We need to ensure our monitoring, as I said, and avoid terbutaline. So you need to talk to your obstetric colleagues for that. If there is a new onset atrial fibrillation with hemodynamic compromise coming in, cardioversion is the mainstay of therapy up there, right? Otherwise, we can use medical treatment. We need to remember that amiodarone is not used in pregnancy. It's a drug that is relatively contraindicated because of its fetal effects. We need to really, prevent and monitor and be on a lookout. And if there is a presence of pulmonary edema, manage it diligently by diuresis, of course, oxygen. And we all know we need to intubate, put this mother on controlled ventilation with PEEP, and then look after her there. Similarly, aortic stenosis, we need to maintain afterload. So, afterload is very important here. We need to have normovolemia, but not hypervolemia, right? But the afterload needs to be maintained. Any hypotension or hypovolemia or any tachycardia occurring will actually compromise the coronary perfusion pressures and lead to ischemia in these patients. Right? They can also be, whenever the transvalvular gradients are less than 25, neuraxial anesthesia, which is graded, can be well tolerated. But we have to remember that at all times when you're putting a neuraxial epidural or a combined spinal epidural, remember, one, you go on a low dose of spinal local anesthetic dose or use only an opioid, and then grade it with your epidurals in small aliquots. Do your intense monitoring using an intra-arterial blood pressure monitoring, and always have a separate line with backup with a vasopressor online. So a phenylephrine infusion is something which is always handy up here, okay? Most of your mothers would come with treated, a mitral valve, so they might have, or an aortic valve, so they might have a mechanical prosthetic valve sitting up there, which will need anticoagulation therapy. What we need to remember is that warfarin is teratogenic, and therefore most of the times would be used in doses less than 5 milligrams per day in the first to the second trimester. And then the obstetricians usually move to heparin in the subsequent later part of the pregnancy. So therefore, you need to balance the risk of anticoagulation therapy and the anesthesia technique that you're going to use. You have to be on the safer zone to the mother, avoid risk of spinal epidural hematoma, at the same time, avoid the risk of thrombosis sitting up there on the mechanical prosthetic valve, right? So that's kind of a balance that you really need to create. The rest of the goals remain the same. So this is what I talked to you about, that all of these, warfarin especially, they cross the placenta and they cause a dose-dependent adverse effects on the fetus, embryopathies and, spontaneous abortions. And of course, if it's continued in the third trimester, there's a risk of intracranial hemorrhage occurring, because the techniques to reverse warfarin effect do not cross the placenta, whereas warfarin crosses the placental barrier, and therefore you need to be careful while anesthetizing this patient. This is a kind of a flow chart that is, of course, useful more for our obstetric colleagues, where in stenotic lesion we primarily focus on doing assisted cardiac vaginal delivery. However, in severe cases may resort to cesarean delivery, where of course you need to balance, keeping in mind your hemodynamic goals of avoiding tachycardia, avoiding more preload, and avoiding causing a drastic reduction in the afterload. That's very, very important in these methods. Regurgitant lesions, on the other hand, if you look at the regurgitant lesions, the physiological changes in the pregnancy that occur are indeed favorable to regurgitant lesions. A regurgitant lesion is happy with an increased F preload. A decreased afterload enhances the forward regurgitant flow and does not cause much of backing. And the myocardial contractility, they really need an increased myocardial contractility to pump that blood ahead. And of course, the heart rate, a tachycardia, a small baseline tachycardia, small increase in heart rate, I would say, preserving the sinus rhythm is favorable to regurgitant lesions. So what we really need to look at in these regurgitant lesions is to avoid any increase in the afterload, the systemic vascular resistance. So during periods of, say, you're doing a general anesthesia or any kind of anesthetic technique, an increase in the SVR is not indicated. We do not want a drastic reduction in the afterload, but of course, an afterload reduction is favorable to them. And we do not want any decreases in myocardial contractility. And therefore, a neuraxial labor analgesia, which is done well, works very well under these conditions. You need to avoid bradycardia and maintain your sinus rhythm. So your vasopressor of choice might be either a low-dose norepinephrine or an ephedrine in this particular case. Okay. We move to one of the nightmares for any anesthesiologist, and that is Eisenmenger syndrome, right? Now, what is Eisenmenger syndrome is basically any kind of a left to right shunt or a chronic left to right shunt, which over time, either because of presence of any of the factors, pregnancy being one of them, infection, or any of these conditions, hypoxia, hypercarbia, acidosis, changes into a right to left shunt. And there is an underlying increase in the pulmonary vascular resistance and pulmonary arterial hypertension. Now, these all, especially during labor, can actually become shift the shunt from left to right to a right to left shunt and lead to cyanosis, and therefore is known as a Eisenmenger syndrome. So when there is a reversal of shunt occurring, especially in larger lesions, this is more common seen in larger lesions. So in the unrepaired TOF or a large VSD or a large PA, and the pulmonary arterial pressures are usually beyond 40. So this is a condition which is indeed a nightmare. And the goals here is, one, to avoid decreases in afterload, the systemic vascular resistance, because more the systemic vascular resistance, more would be a drop in the systemic vascular resistance would actually mean that the pulmonary vascular resistance increases and the shunt moves from right to left and causes more cyanosis. Right? So cyanotic episodes need to be taken care of. There have been reports of careful titration of neuraxial anesthetics, but of course you have to be careful because you do not want any drastic decrease in the afterload coming in, because that would be dangerous for this mother. We also need to minimize the pulmonary vascular resistance by avoiding hypoxemia, hypercarbia, so over-sedation should be avoided. And you need, most of the times we'll need GA with well-controlled ventilation. And of course, needless to say that, methergine, carboprost and all would need to be avoided in these patients strictly. We need to maintain an adequate blood volume. So a strict, fluid balance is very important in these mothers. Having said that, hypovolemia is also not indicated in these mothers, can be dangerous to these mothers as well. And very important is to avoid a paradoxical embolism. So all your IV lines should have filters. You should ensure that not even a microemboli from the exteriorization of uterus to use of air in the for loss of resistance in epidural space conformation should not occur in these patient mothers at all, right? Similarly, there would be a coexisting pulmonary arterial hypertension, and the goals would primarily remain the same. That is, we minimize the pulmonary vascular resistance, we maintain adequate preload, we avoid myocardial depression, and we maintain an afterload, but we do not have sudden drastic drops in afterload. That's very, very important for these mothers. A left to right shunt is a kind of a shunt that tolerates pregnancy well, especially when you have small ASDs and VSDs and your pulmonary arterial pressures are less than 40. And therefore, you can manage these mothers well with even a neuraxial analgesia or anesthesia. What is important again here is to avoid paradoxical embolism. Air embolism can occur in these patients as well. Now, coming on to iotopathies, we see less often, of course, they're seen more often in Western countries. Marfan syndrome actually is one of those which have an underlying iotopathy. And we have to remember that as the aortic dimensions increase beyond 40 and 45 and 50 millimeters, there would be a risk of aortic dissection happening during labor, especially. So therefore, we need to minimize the aortic wall tension in these mothers. And the best way to do is having an excellent labor analgesia, especially if your aortic dilatation is less than 40 millimeters. Remember, no Valsalva. So if you are doing a cardiac assisted vaginal delivery, has to have dense sacral coverage. A cesarean delivery is usually indicated in case you are looking at a high-risk mother where the diameters are above 40, 45 or 50 millimeters. And you need to minimize your hemodynamic swing. So if you're giving GA, remember, GA has to be a cardiac GA where you do not get a hemodynamic swing on either side occurring drastically. That has to be well titrated. Same are the considerations for coronary artery disease. We see it less often because our mothers are pretty younger. But in the urban side of our country also, we have mothers with advancing age and, of course, underlying comorbidities, especially diabetes and hypertension. So therefore, the same principles as would be there for any cardiac patient going for non-cardiac surgery of avoiding tachycardia, maintaining afterload, monitoring for ischemia would be important here as well. Now we come to one of the most dreaded, and of course, I think this is the last that I talk of, is heart failure. And we all are, we are scared of peripartum cardiomyopathy because more often than not, the symptoms of peripartum cardiomyopathy are confounding. Fatigue, breathlessness are going to be present even in mothers who do not have an underlying cardiac problem. But what we have to remember is an unexplained tachycardia, an unexplained persistent tachypnea. And so mother says, initially I would, use one pillow. Now I need 4 pillows. I am tachypnic. I do not wish to, move about much in my house and have extreme fatigue. We must interrogate them. We must subject them to undergo an echocardiography and look for peripartum cardiomyopathy. By definition, a PPCM is a heart failure secondary to left ventricular systolic dysfunction with a left ventricular ejection fraction of less than 45%. And occurrence usually occurs towards the end of pregnancy or in the subsequent months following pregnancy. It has been even shown to occur 5 months later after pregnancy. And of course, you do not get an identifiable cause for heart failure in these mothers. What are our hemodynamic goals? Our goals here is to understand and remember what the pathophysiology presents to us. So there is an hypovolemic state in pregnancy and a failing heart. So there is a high propensity towards pulmonary edema and heart failure. And of course, the mother had a previous history of PPCM in the previous pregnancy, then she is at a very high risk of left ventricular dysfunction in the subsequent pregnancies. And remember, ACE inhibitors belong to a class X of the drugs where they have to be discontinued during pregnancy due to teratogenicity, whereas this is a mainstay of therapy for any heart failure patient, right? So it cannot be used in pregnancy, during pregnancy, can be used in the postpartum period. So our hemodynamic goals would be having a normal sinus rhythm, avoiding brady and tachycardia, maintaining the afterload. So we do not want neither hypo or hypertension. So therefore, you will have to have a beat-to-beat monitoring. You can employ in milder cases neuraxial anesthesia. But remember, if the patient has an NYHA 3 and 4, there are no regional anesthesia techniques. She is indeed a candidate for a careful cardiac GA coming in. Okay. You need to treat the hypotension diligently, goes without saying. And of course, titrate your oxytocin infusion, recognize and treat the hypertensive disorders of pregnancy. And if we need to maintain contractility, dobutamine or milrinone can be used. What you need to remember that milrinone's bolus doses need to be avoided, but that can cause a sudden drop in the afterload as well. Okay. Epinephrine is a good drug because it has both alpha and beta effects, and we need to, always be on the lookout for pulmonary edema and manage it. So the mainstays are preload optimization for PPCM, right? Afterload optimization, optimization of contractility, and of course, optimizing and preventing a heart failure from coming in by looking at elements of rate, rhythm, and of course, anticoagulation. ACE inhibitors and ARBs can be added in the postpartum period after delivery. There is a role for them. Now, having talked about a gamut of cardiovascular diseases, is there any role of infective endocarditis antibiotic prophylaxis, right? So what the latest guidelines talk about is that there is only a role in high-risk cardiac conditions and not in low risk. Say there is a presence of prosthetic valve, an unrepaired cyanotic congenital heart disease, or a repaired congenital heart disease with prosthetic materials, and a history of infective endocarditis. You can use the modified Duke's criteria to know whether or not this patient fits into presence of infective endocarditis or not. So these are the places where you would give your, IE prophylaxis to these mothers. Of course, routine surgical site infection prophylaxis before skin incisions can be employed in cesarean sections. So to conclude this whole gamut of a difficult and a complex talk, I would say, what is important for us to remember is to do a thorough pre-anesthesia evaluation with your heart team as a multidisciplinary approach. Risk stratify your mothers, identify your class 3 and class 4, and treat them in the right place, in the right location. If they need to go, transfer them as early as possible to a higher center. If your center does not support, does not have that level of care, please transport. There's no egos up here. Optimize the mother medically before delivery as much as possible, also during the peripartum period. For preload, so that I've told you about the 5 areas, the 5 pillars of managing any cardiovascular disease: optimizing preload, afterload, heart rate, rhythm, and contractility. So these are the things that really need to take care of. Early labor epidural timing can always be done, keeping in mind the anticoagulation dosing, safe dosing timelines, right? And you need to always use one saline, no fluid boluses, titrate your epidurals very gradually, no test doses, and then, in a graded manner, try to achieve a dense sacral block, especially during the second stage of labor. A single shot spinal is something that I would rather not like to have. I would always like to have a catheter backup because we like to go low on doses for local anesthetic drugs. So it has to have better hemodynamic stability. There's a big no to spinal in mothers who cannot lie supine. They need to be given general anesthesia, right? An invasive intra-arterial blood pressure monitoring is a mandate now in these mothers. And of course, we need to remember to prevent and treat hypoxemia, hypercarbia, pain, and acidosis. So remember your 5 pillars of what to prevent and treat. And of course, the 5 areas that you need to optimize. So these are the areas that you need to optimize. Remember, whatever your underlying pathology is going to be superimposed by this pregnancy-associated cardiovascular changes. And that is an interplay that you need to keep as near normal as possible while you anesthetize or give analgesia to these mothers. Thank you all for a very patient hearing, and I invite you all in December from 8th to 11th at PGI Chandigarh for a National Obstetric Anesthesia Conference. Welcome you all, and thank you so much, and we'd love to take questions. Thank you.
Thank you, madam. A nice presentation covering all the aspects of the cardiac patients in pregnancy. Now we will move on to the questions. Sivaprasatha, sir, please.
There is one question asking what is the recommended time period from anesthesia to delivery of fetus, ma'am? Should we make it faster?
It is recommended to make it faster, but then what you have to remember is that you need to optimize your hemodynamics. That's more important for us at this point in time rather than hastening it out, because sudden decompression, of course, is going to cause auto transfusion, and you have to be ready to deal with that. So that's very important. Of course, we cannot delay it beyond a standard timeline, but that would be detrimental to the neonate, right? But you have to be prepared beforehand. So a cardiac, a patient who's coming to us for cesarean delivery, say in an obstetric emergency, you have to, that is why I said placing an arterial line much before this emergency happens is going to be of much use to us, in these particular conditions.
The other question is on when should we transfer the patient to a tertiary care hospital?
As early as possible. Goes without saying. As early as possible before she actually gets into labor.
Okay. The role of bromocriptine in peripartum cardiomyopathy, ma'am.
There is a role coming in, of course, not very well established. So I didn't talk about it much. Of course, it was there on one of my slides.
One question on the use of 2 pulse oximeters.
Mm-hmm. So basically, the premise of using, sorry, anything else to that question?
No, ma'am.
The premise of using 2 pulse oximeters is based on the fact that because we are monitoring a mother who has been placed a neuraxial epidural, say, for example, into a labor floor. So one is part of is an exclusive monitor with you, and the other is part of just to look at the pulse oximeter SpO2 readings. The other should have a proper waveform reading coming in. The waveform, any loss of waveform basically tells you that there is been a loss of, the patient has gone into a pulseless arrest. I would say it more accurately. And you need to palpate your pulses, of course, it goes without saying. Yeah. You shouldn't just rely on that. There can be so many technical issues that come in with pulse oximeters.
What is the targeted SpO2 for cyanotic heart disease during anesthesia?
I would say anything around 90 to 94% would be ideal. Yeah.
Madam, this question is from me only because I have taken your Epstein anomaly case. Preoperative, it was 86%. So but I don't know how much target I have to achieve during the anesthesia. It is a preoperative target or intraoperative should be higher.
So a preoperative target is okay, but what we have to remember that intraoperatively there could be additional stresses coming in. You will have additional boluses of fluid coming in. A preload is going to increase. There would be a decrease in the afterload. So you need to keep your SpO2 target somewhere around 94 to 95. I would rather target these values rather than go low.
Okay, thank you.
Because you can reverse the shunt, at times, in some of the patients. Yes.
One more question from me, ma'am. What is your experience in combining general anesthesia and epidurals, ma'am? Of late, in my center, where patients have a pulmonary hypertension or a pulmonary edema in the baseline, or a patient who has a low EF, we are combining both. So, what is your experience, ma'am?
So I think when you're combining both, you have to be very careful. Careful in the sense that once you have put in an epidural, the dosing in the epidural has to be very, very in a graded manner. Small aliquots of dilute solution, and when I say dilute solutions, if it's for labor analgesia, it should be less than 0.125 or that should be your concentrations up there, right? Or 0.1 if you're using ropivacaine. But if you're and you're simultaneously adding, so that would act as a good source to create a graded decrease in the SVR, right? On the other hand, if you're giving GA, you have to be careful in not employing methods, and your techniques have to be tailored to see that your hemodynamics stays stable, especially during induction and extubation. And of course, at delivery of baby. So these are the 3 time zones where you will have to be really careful about it. The drugs that you're going to use, the way they're going to titrate them. Of course, it's good because they kind of complement each other. I haven't used them, honestly, together in these group of mothers. But I think it's a good thing. If you're doing, you should compile your data and, of course, publish it as well for all of us. That will be great. Yeah.
Thank you very much, ma'am. It was a really wonderful talk. This 1 hour where you were on the right time, the right course of on the topics. Thank you very much, ma'am. We had a very good Sunday today.
Thank you so much.
Thank you, ma'am.
Thank you, madam. Thank you. Given bad view of this concept behind the cardiac patients coming for pregnancy and delivery. Thank you so much, madam, for sparing your valuable time. And also, we come to the end of the session. I thank the Akrula, the sponsor, and the A1 Logics, the host, and the Anesthesia TV. And I thank the coordinator, Dr. Sivaprasatha sir also. I thank the viewers. We will meet next week with an interesting topic. With that, we conclude this session. Thank you.